Hello, everybody. My name is Dr. Bybee. I'm a family physician giving a lecture today about point of care musculoskeletal and soft tissue diagnoses and therapies that you can offer to patients here in the clinic. This is meant for resident and medical school education. This is not meant for direct medical advice. Please enjoy and would love any feedback. I'm a family physician who's been practicing for 8 years now. I have a great interest in athletics and movement in general. I've had lots of injuries. I've done a lot of physical therapy and massage. I've worked with a lot of patients with chronic pain and injuries. I think this provides a slightly unique and hopefully helpful approach to people earlier on in their training so that they can offer relevant and actionable things to their patients while in the office. We all see lots of injuries and chronic pains, and in my experience, formal medical education in musculoskeletal injuries and rehabilitation is insufficient to the task of what we deal with on a regular basis. And it can be difficult to get patients in with physical therapy and boilerplate advice such as rest ice, ibuprofen, compression, elevation, and stretching doesn't get patients where they want to be and is not quite specific enough for anything that they might come to the clinic with. And the good news is that as family physicians, we have long-term relationship with patients. And if we have a framework to help them with, over time, they can give us feedback on what is working or isn't working and hone in on how we can get them living their best lives and moving to the best of their ability. I'd like to start this with a brief case. Imagine we have a 45-year-old sedentary office worker who has 3 months of medial elbow pain after joining a rock climbing gym about 4 months ago. No prior experience climbing, not terribly athletic at baseline. They don't recall any specific injury. And it's been gradually worsening over the last few weeks. It's worse when they try to do exercises such as pull-ups. It typically doesn't hurt at rest, but it tends to hurt more if they've been active for long periods of time while not moving the arm and then starting to use it again, such as gripping a coffee mug. It can be a bit better when they're warmed up on very easy climbing routes, but tends to hurt after hard climbs and at the end of the day. Exam is largely normal, except for palpable pain at the medial epicondyle of the elbow. What would you recommend moving forward? Should we get imaging of some kind? Is there any labs that would help? Do we jump right to injections? Let's just give the guy some ibuprofen. Of course, we would recommend some sort of physical and/or occupational therapy. And my question to the learners is, what else might we look for in the physical exam? This is a cheeky slide where we can give somebody a diagnosis of a very specific injury, but giving it a name doesn't necessarily tell us what to do about it. I feel very often we can miss the forest for the trees in the diagnosis and treatment of chronic musculoskeletal pains. So today, my goal is to introduce some frameworks for the identification and resolution of painful movement. We're going to go over some hands-on assessments. For those of you watching offline, you can attempt to do this with a partner if you have one, because I think it's helpful to build your own proprioceptive intuition for these diagnoses. We're going to learn some basic mindfulness and breathing techniques as it relates to the body and movement, and maybe we can learn something to apply to ourselves. A couple of broad frameworks that I like to use are thinking about how we move and how we stand, our biomechanics and our posture. We can also think about the tissue itself, the muscles and the tendons. My metaphor is we want to go from rawhide that's stiff to suede that is supple. We want to learn how to engage our nervous system to prevent overguarding while being under-mindful. In fact, do the opposite, be appropriately guarded and quite mindful. And the key takeaway is that the way out of pain is to do a reverse movement or an eccentric. If you think about an eccentric or a negative or a controlled lowering as opposed to a concentric or lifting maneuver. The key takeaway is that the way out of pain is a slow, mindful, negative movement or an eccentric as opposed to a concentric or shortening of the muscle. And if we can do this with control, a braced core, and appropriate breathing. I'd like to begin with posture. Your elbows begin at your feet. Once again, just a cheeky way of saying we're all connected. If you look at the picture on the right, you can see what happens if somebody has slightly flat feet and a bunion, such as myself. We can collapse with genu valgus, or a knee that's turned in. We drop our hip. We have to compensate with our spine. And, we have to level out our shoulders, but that means our collarbones are uneven at the top of our thoracic spine. The point I'm trying to make here is if we focus on the point of pain, we can miss downstream or upstream causes that are contributing to movement problems. And the weak link in the chain is where the pain is, but it's not the source of why the pain started. So as we further our exam of this patient, we notice that he has anterior pelvic tilt, kyphosis, and internal rotation of the shoulders. Anterior pelvic tilt is if our hip bones are tilted forward, almost like we're kind of sticking our hips backward and rotating our pelvis like this, as opposed to a neutral pelvis. Kyphosis is when we have rounded shoulders and a forward neck. So as we examine our patients with chronic musculoskeletal pains, we want to pay attention to how they're standing, what's their foot position, are their ears over shoulders, over hips, over knees, over midfoot? Are they arched in the back? Are they rounded at the back? Is their neck forward of their shoulders? Do they tend to carry one shoulder higher than the other? Noticing all these things and making note to come back to later will be helpful when coming up with a movement plan to get these people moving and feeling better. An exercise that I would like you to try is how to start with lower body alignment. Most people will either stand wide-toed or narrow-toed. So instead, what would happen if we stood about a fist distance apart between the big toes with parallel feet? Then squat down ever so slightly, shift the weight to the outsides of your feet or the blades of your feet, and try to create a big arch. Spread your toes as wide as possible and then gently set them down like you're trying to grab some sand. Then, when our big toes are very gently touching the ground, maintaining tension in the arch, and our knees are pointed out slightly, can we stand up and hold this position? This builds up arch and ground contact and stability all the way through the leg. If you notice people who don't have the best of arches or awkward foot posture, you might ask them to do this while they're waiting in line at the groceries. An important concept in moving our body and standing and keeping our body healthy and stable is called tensegrity, where we have a push and a pull on opposite sides of the body, from left to right or from front to back, that keeps us upright. If you think about a telephone pole or a bike wheel, what makes these structures stable and strong is not the rigidity of the material itself, but the tension placed on them from the guy wires or the spokes. If you think of your spine like this, your spine isn't strong because it's a rigid column. Your spine is strong because of the muscles that support it, such as your abdominal muscles, erector spinae, quadratus lumborum, psoas, etc. So, how can we best support our spine? I'd like to take a minute to practice another exercise where we build some core tension through our abdomen. So if you think of your diaphragm as a lid and your pelvic muscles as a bowl, we can create a pressure container with our abdominal muscles, thus supporting the spine. Again, for our practitioners, I just want to acknowledge that a lot of people might be quite sensitive due to histories of trauma or otherwise in their body and carry it in areas of the pelvis and abdomen. So just be sensitive and have done a good thorough history to make sure that you're patient won't be upset or triggered by any of this. First, we need to make sure that the lid and the bowl are aligned and flat with each other. So if you think about having a line from your rib cage at your diaphragm and a line from your pelvic bowl, we want to keep them flat. We don't want them splayed open and we don't want them collapsed, especially as we, bend over and move around. Can we keep these lines stable and parallel as we're doing things? Once they're stable, you can then take your fingers and put them in between your rib cage and your hips. Most of us are going to be soft in this area. And now what I want you to do is think about filling that area with air and pushing your fingers out by tensing the muscles on the side of your abdomen. Like so. You can see that now my core is braced. At least for me, it feels like I'm pulling my rib cage directly down into my pelvis. Again, without collapsing it, pulling them straight down together. Why is a braced core important? A quote I heard one time was, "You can't push rope," meaning that if you're trying to move forward by pushing something from behind, if it's a big block of jelly, it's going to be very inefficient to move it forward. Whereas if that block of jelly was a little bit rigid, as you apply force from it, you can then push it quite efficiently. So the more that we have a stable braced core, as we push from our legs through our hips, we'll be able to move our entire body in a controlled, organized manner. One cue that I like to use for this is, could you jump from any position? So starting from the first exercise where we get on the blades of our feet, build some arches, get a gentle squat, make our ribs and our pelvis parallel, brace. This would be a very strong position to jump from. Whereas if we are, in contrast, wide legs, slack posture, I at least have a hard time making a good coordinated jump from that position. So as you're walking around in daily life, would it be easy for you to jump at any point? And if not, take a minute, reset your feet, reset your core, and keep going on with your life. Getting back to the case, the patient was showing us a video of his recent workout, and he's doing a pull-up. Now, for those of us who are not exactly gym inclined, we want to note where his elbows are relative to his center of mass and where his neck is relative to his shoulders. The human body moves best when we load ourselves up as a rotational spring through each of the joints, with no one joint going through its maximum range of motion. We are not a series of gears and levers, we are a series of rotational springs and whips. I'm going to use a row as an example of how to use rotational movement to set up a larger whole body movement. If I'm holding on to something and lean back and let my shoulders go slack, they naturally want to protract or go forward and elevate, having my shoulders come up near my ears. Now, if we start with thumbs down and work towards good posture, the first thing I'm going to do is retract my scapula and depress them. So I'm pulling my shoulders down and back, and as I do that, it makes it easy to rotate my thumbs outward. And if you look at my body line, you'll notice that just pulling on the scapula and starting some external rotation starts the whole body movement, making it very easy to complete the row. And in reverse. Whereas if we do not reset our scapula and get into external rotation, this is a very weak position, and this internal rotation and elevation of the scapula sets us up for rotator cuff injury. Again, this is just one example, but noticing where patients are moving with overly linear or rigid maneuvers versus utilizing rotation through ankle, hip, knee, shoulder, etc. By moving in a spring rotation, we tend to avoid injuries, be more efficient, and thus have less pain. Another thing that I've found is that a reason a lot of us hurt is that our range of motion can be limited due to tight places along the arc of movement, due to things like bone spurs or stiff tendons or cysts anywhere along the joint. Now, what I want you to picture in your mind today is if you were to suddenly wake up and you were in an egg a little bit bigger than your own body, kind of like what we see in this picture here. Now, it's very dark and you can't see inside of this little egg that you find yourself in. And if you were to stand up suddenly, you might find one of these angles or corners. It might feel like a spike if you were to stand up suddenly and touch into it. Whereas instead is if we are slowly moving around in this joint cave, pain cave, joint box, whatever you want to call it, we can feel around and find where those angles are. Once we know where those angles are, then we can gently avoid them and move around them. But wouldn't it be nice if they weren't there in the first place? And so if we do a joint scour, a concept that I've borrowed from Stuart McGill, who is probably the leading researcher on back pain, we do a joint scour. What this does is it allows us to explore the rim of the capsule as well as kind of shave off the tips of these spikes that are around our joint. So as Fred here is moving through a range of motion, we can find where it's a little bit stuck, and instead we just kind of go back and forth where that angle is. See, he just gained a whole bunch of range of motion from his hip just by working on his shoulder. Everything is connected. So by moving back and forth very gently with a calm face, not with a tense face, we can shave off those spikes and eventually smooth them out so that as we are doing our normal activities, they won't cause as much pain, and we'll have extra reach or range of motion. Moving back to the case, as we examine the patient with palpation, we notice that there's a firm, fairly rubbery or spongy nodule right over the medial epicondyle where he's having the most pain. And emanating from that, there are linear palpable cords in the ventral forearm. These are what are colloquially known as muscle knots, where the muscle and tendon fibers tend to get sticky and adhered to at the tissue level. With use, abuse, and misuse, we cause damage, both microscopic and macroscopic, and unfortunately, our healing capacities as an adult are not like they used to be when we were 7. And so we accumulate fibrosis, which is stiffer than healthy tissue, and that stiffness and shortness contribute to some of the pain and are visible or palpable as those muscle knots. So a mental image that I like to use is thinking about going from rawhide to suede. Imagine you have an old baseball glove that's stiff leather because it's been outside or unused for too long. So if we get it warm, we get it oily, and we work the tissue, we can break up some of those microscopic adhesions and get the layers of the muscles and tendons stretching, sliding, and gliding over each other again. You can also think of your tissues as a similar consistency to bread dough. So we're going to want to knead the bread dough, or as the tissues accumulate wear and tear, they can also kind of get edematous. And so other ways that we can help the tissue heal or get more functional is to wring it out and squeeze the edema out of the tissue in problematic areas. Another thing that's important to consider is muscle knots, where they happen at layers of muscle fibers that are in different orientations. This is just one example in the abdominal area, where there's horizontal, transverse, and angular fibers, all very closely situated in very thin slices. There are also hypothesized fascial trains that, as you see here on the right, are organized in kind of spiral fashion, linking multiple parts of the body across several joints. Again, alluding back to the whip and spring rotational movements that we want the human body to be doing. This is just another animation showing how the tissues are supposed to slide and glide past each other, but if there's some adhesion or fibrosis between layers, it will inhibit normal, natural movement. And things like muscle scraping and massage can help to, in theory at least, break up some of these adhesions and get the tissues moving again. So now we're on to a bit of the therapy side. What do we do once we've identified where the painful parts of the body are? How do we actually get them feeling better? So in this case, the person had a medial epicondylopathy, and we want to do some eccentrics or negatives that are going to help lengthen these fibers, break up fibrosis, while at the same time strengthening them and restoring function. So at the medial epicondyle, we have muscles that are responsible for grip, wrist flexion, and pronation or internal rotation. So we're going to do some reverse of each of those maneuvers. So for example, we talked about grip and wrist flexion. And so what we would do is load up some weight. That's a comfortable amount for each person. It's going to be quite specific, but ask the person and get a sense of their limitations. We load up the weight with both hands so that we're not shortening it under excessive tension. And then we're going to, over a 3 to 5 second count, lower the weight. 5, 4, 3, 2, 1, and then work through the grip. 5, 4, 3, 2, 1. Reset with 2 and repeat. 5, 4, 3, etc. Can we go for 5 to 10 repetitions of this and do it for 3 sets in a day? And then we talked about pronation, so we're going to do some reverse pronations. It's helped to have an offset weight for this specific exercise, like a hammer. You can use a dumbbell like this. So we get it set up to vertical with 2 hands, and then we're going to slowly lower it. 5, 4, 3, 2, 1. Reset. 5, 4, 3, 2, 1, etc. What we're going to go for is an interesting level of sensation. We don't want to do anything that's going to make somebody wince or scrunch up their face, but what's the maximum intensity that they can do while keeping a calm face with controlled breathing? There's a variety of self-massage techniques to help with the fibrosis and adhesions I mentioned earlier, such as tack and floss, where you find something relatively firm, place it against the area of pain, again, at an interesting level of sensation, the most that you can maintain with a calm face without squinching. And then once the muscles are tacked down, you go through range of motion exercises. Can you do 30 seconds of this for each painful spot? So how do we discuss dose and timing with our patients. Like any good therapy or medication, these are critical components. It took time to get here. It's going to take time to get away. And we need to treat the rehabilitation like a strength training program. Changes to the tissue at that level are going to happen over the course of 3 to 6 months, just like somebody who's in a bodybuilding program. The same fundamental principles apply on both a tissue and neurological level. I usually aim for 3 to 4 days per week for each problematic joint or movement. You want to go for about 3 sets. A set is a group of exercises in the 10 to 15 repetition range, or if you're doing something static, in the 30 to 60 second hold range. So as we document this in our note, we would do diagnosis medical epicondylopathy. To be slightly pedantic, once it's chronic, there's typically no further inflammation. It's a fibrosis, not an isis. And because it hurts or is dysfunctional, it's an opathy. As we mentioned, 10 to 15 repetitions, each repetition lasting 3 to 5 seconds. Take a 1 to 2 minute rest and repeat that 3 times in a day, aiming for 3 to 4 days per week. On a side note, we're usually imbalanced creatures, so it's good to practice balance. So for each exercise that you do, even if the other side is not hurting, it's good practice to do that to prevent injury, as it's probably a ticking time bomb and likely to cause some problems in the future. Offer guidance on soft tissue release and self-massage. Advise them that you should see moderate or noticeable improvement in about 2 months, and if they're diligent, it might take up to 7 months for complete resolution. Our patient follows up with us at about 3 months and says he's 60% better and feels plateaued. He's been doing the exercises but hasn't really done any exploration on how to make the next step. He's doing the eccentrics we recommended, but he isn't working the opposite side of the joint. When patients are plateaued, how can we take the next step? Beginning to incorporate the nervous system can be quite helpful. So whenever we activate one side of the body, we neurologically deactivate its antagonist. So if we're continuing to have pain here, if we were to activate its antagonist, that would deactivate the area that we're working on. So as we advise patients to do exercises for the painful area, we also want to make sure that we're advising them to do a similar or appropriately balanced movement on the other side of the joint or the other side of the body, depending on the case. Other things to consider are integrating breathing with your repetitions, as inhalation could be grossly thought of as a sympathetic activity and exhalation as a parasympathetic activity. So on the negatives, long out breaths deactivate the overly activated, protected, and painful parts of the body. Another concept is tense and release. Maybe you've talked about this with patients as they're trying to get to bed by doing some progressive relaxation exercises. Sometimes it's hard to turn off the muscle, but if you squeeze it and then shake it, you can turn it off. So by actively turning it on, it gets easier to then turn it back off. Many of us are seeing more and more patients with hypermobility syndromes. One of the more common ones is Ehlers-Danlos, but there's many ways that this can show up. Working on eccentrics can be especially helpful in this population of patients because they're more prone to injury and overuse. So doing exercise that focus on control and starting from a place of strength can be helpful. For example, if we're going to do a row, we would start by holding on to something with a upright posture, all the weight's on our legs. Then we turn on our body in a perfect posture, shoulders down and back, externally rotated, and then go into an eccentric just as much as their joints or their muscles allow. And then we can take a step back and reset. We also want to advise about trying to avoid hyperextension, especially of the elbows and knees. So referencing the picture in the slide here, we want to have a microflexion in the joint when we're doing our movement practices, such as holding a plank rather than just doing a push-up. We can hold the top of a plank with a microflexion in the elbow. Or, for example, doing wall pushes. We get next to the wall at a comfortable distance, take a step back, and then we put more and more weight into our hands as much as our body allows us, as if we're trying to knock this wall over. Instead of trying to pick up a heavy weight that might cause injury, we are activating the muscles, but starting from a place of safety that we can always back off from at any point without having to drop a weight or ourselves. Many of us in family medicine have a large caseload of patients in the second half of their life and for various reasons become deconditioned, a little bit overweight, and now we're dealing with chronic pains of many kinds, such as knee pain with normal x-rays. They're worried they can't do anything. So where should we start? Referencing the hypermobility patient from a second ago, wall pushes are a great place to start. We want to reverse engineer how to move, starting from a static place and building up tension through the body with a braced core and engaged feet. Remember, movement is a lifestyle. We want to figure out a way that we can practice it anywhere where we don't need to be tied to our gym or any specific place. So creatively explore with your patients what their environment is like and what are ways that they could use their table, their desk, or a belt to keep their bodies maintained and healthy. There's a lot of things that we can do with basic everyday objects that most people will find in their homes, such as brooms, towels, tennis balls, etc. A principle that I'd like everybody to take away is teaching other patients how to connect their hand to the ground through a braced core. And from there are three basic movements. There's a push, a pull, and a squat. And you can also consider that everything is either a plank or a lever. So that gives us a framework to get creative about wherever they're starting. There should be some way that we can help them integrate a leg movement, a pull movement, and a press movement. Some standard tools of the trade that I find helpful that might not be standard in the home: massage canes, tennis ball peanuts for rolling up and down the spine to get at those hard to reach places between the shoulder blades, exercise rubber bands, and a foam roller. Please consider checking out my other videos for simple home-based physical therapy exercises and rehab maneuvers. I make zero money for this. I just want my patients to feel better. I'm always open to new ideas, so please send me some feedback. These are a few people who I have stolen a lot of great ideas from. Please check out their content and let me know if you find others that are quite useful.